Good afternoon. I'm Robin Rudowitz from KFF, and I want to thank you all for joining us in our annual survey of state Medicaid. Provides comprehensive coverage to nearly 90 million low-income Americans, and the program is the primary payer and provider of long-term services and supports. Medicaid has also played a key role in helping to respond to the COVID-19 pandemic, and many states are leveraging Medicaid to help address the nation's behavioral health crisis and health disparities. Today, we will hear more about many of these trends in Medicaid policy. Next slide. We have a packed agenda, so here's the roadmap for the next hour. I will set things up with a quick overview and some context on national Medicaid spending and enrollment trends. I will then turn to Libby Hinton from KFF and Kathy Gifford from HMA to highlight some key findings from the policy report. Next, we will hear from Diane Hasselman from the National Association of State Medicaid Directors. And finally, we're thrilled to turn to a discussion with two leading Medicaid directors to hear more about what's happening on the ground in the states. We have Allison Taylor, Medicaid Director for Indiana, and also the President of NAMD's Board of Directors, as well as Amanda Castle-Craft, who is the Assistant Secretary for Mass Health at the Massachusetts Office of Health and Human Services. I will not take time to go through everyone's extensive and impressive bios, but you can find that information posted on the event webpage. I really want to thank all of our panelists for joining us, as well as the report authors and all the other staff from KFF and HMA who helped with these reports. It is a big team effort. I also want to thank NAMD, all of the Medicaid directors and their staff that helped to take time to surveys so we can provide such a robust picture of what is going on with state programs across the country. Finally, before I dive into the content, I want to let you know that the briefing is being recorded and a link to the recorded version will be emailed to everyone later today. We will be saving some time at the end for questions, so please enter any questions that you may have using the Q&A function at any time during our discussion. Next slide. The public health emergency, the public health emergency, or PHE, tied to the COVID-19 pandemic has been in place for more than 2.5 years, and it has had a profound impact on the finances, ongoing operations, and priorities of state Medicaid programs. In collaboration with HMA, we fielded our 22nd annual survey of Medicaid programs last summer, as most states were beginning state fiscal year 2023. In this presentation, we will discuss key findings from two reports that we released today: our analysis of national Medicaid enrollment and spending trends, and our detailed look at Medicaid policy changes across states for state fiscal year 2022 and 2023. Next slide. As was the case in last year's survey, estimates for state Medicaid enrollment and spending trends were tied to state assumptions about the end of the PHE. As you may know, early in the pandemic, the Families First Coronavirus Response Act included requirements for states to provide continuous coverage for Medicaid enrollees in exchange for enhanced federal matching funds. These provisions have helped to ensure stable coverage for Medicaid enrollees and to provide substantial fiscal relief to states. At the time of the survey, most Medicaid officials had assumed that the fiscal relief and continuous enrollment requirements would end by December 31st, 2022. As a result, after steep increases in Medicaid enrollment in recent years, overall, states projected a slight decline in enrollment in fiscal 2023, as they anticipated that they would restart Medicaid redeterminations partway through the state fiscal year. Since enrollment is the primary driver of total Medicaid spending growth, we see that states were also projecting slower total spending growth in fiscal 2023. Next slide. The state share of Medicaid spending typically grows at a similar rate as total Medicaid spending growth unless there's a change in the federal match rate. During periods of fiscal relief, state spending typically declines and then it increases sharply when that fiscal relief ends. This pattern occurred with fiscal relief provided during the Great Recession. Since many states anticipated the fiscal relief would expire, they also anticipated that state spending would increase sharply partway through fiscal 2023. We know that the PHE was recently extended to mid-January, so the enrollment and spending growth patterns that states had initially projected may be delayed. I am sure that we will hear a lot more about the challenges of the PHE unwinding throughout our discussion today. But with that, I will now turn things over to Libby Hinton to discuss some findings from the policy report. Next slide.
Thanks, Robin. I'll turn now to some of the findings from our policy report. We won't have time to cover everything in the report today, so we hope you will access the report on the KFF website to learn more about the array of Medicaid work underway across the country. As in the past, the report addresses policy changes in fiscal year 2022 and changes implemented or planned for fiscal year 2023 across a variety of policy areas, including delivery systems, health equity, benefits, telehealth policy, provider rates and taxes, and pharmacy policy. I'll turn first to delivery systems. Next slide. Capitated managed care remains the predominant delivery system for Medicaid in most states. As of July 2022, there were 41 states, including DC, that contract with Medicaid managed care organizations, or MCOs. This number is unchanged from last year. North Carolina is the latest state to be included in this count, having launched comprehensive risk-based managed care in July 2021. Although not counted in this year's report, Oklahoma expects to implement comprehensive MCOs in fiscal year 2024. While managed care has continued to grow, the managed care penetration rate has remained relatively stable across the various Medicaid eligibility groups. As you can see in the slide, of the 41 states with MCOs on July 1, 2022, 35 enrolled 75% or more of their total Medicaid enrollees into MCOs. This includes the 10 states with the largest Medicaid enrollment that account for over half of all Medicaid beneficiaries in the country. Consistent with previous years, children were most likely to be enrolled in an MCO, and seniors and people with disabilities were least likely to be enrolled in an MCO. In addition to expanding the use of comprehensive MCOs, state Medicaid programs have also expanded their use of other service delivery and payment reforms, including patient-centered medical homes and accountable care organizations. Next slide. The COVID-19 pandemic has highlighted and exacerbated longstanding racial and ethnic disparities in health and healthcare. Over the past few years, the federal government and many states have identified advancing health equity as an important priority for the Medicaid program. For example, states can leverage managed care contracts to promote health equity related goals. On this year's survey, we asked states that contract with MCOs about whether certain contract requirements related to health equity were in place or planned. As you can see in Figure 8, in fiscal year 2022, similar numbers of states, about 1/4, reported requiring MCOs to have a health equity plan in place, to meet health equity reporting requirements, or to train staff on health equity or implicit bias. Fewer states reported requiring MCOs to seek beneficiary feedback to inform health equity initiatives, to have a health equity officer, or to achieve NCQA's distinction in multicultural healthcare. Notably, the number of states with at least one health equity MCO requirement is expected to grow in fiscal 2023 from 16 to 25 states. Also, this year's survey asked MCO states whether financial incentives tied to health equity were in place, and if MCOs are required to participate in performance improvement projects focused on health disparities. Data from these additional questions is available in the report. Our survey also included questions to gain a better understanding of state strategies to improve the completeness of race, ethnicity, and language data, which is essential for identifying and addressing disparities and measuring progress over time. Next slide. Consistent with trends over the past 10 years, more states are adding or expanding covered benefits than are making cuts. In fiscal year 22 and fiscal year 23, states are focused on service expansions across the behavioral health continuum, including programming for youth, physical and behavioral healthcare integration, and crisis services. States are also focused on expanding pregnancy and postpartum services, preventive services, dental services, and services related to unmet enrollee social needs. For example, several states have recently received CMS approval to provide certain evidence-based health-related services like housing and nutrition supports to certain high-need enrollees, like those experiencing or at risk of homelessness. Next slide, and now I'm going to turn it over to my co-author, Kathy Gifford, to continue with the findings.
Fantastic, thanks, Libby. Now, early in the pandemic, all states used emergency authority to expand their telehealth coverage. And in both last year's survey and this year's, we were eager to learn whether states plan to make these expansions permanent. Last year, most states had not yet acted, but this year, 2/3 of the states reported either a telehealth coverage expansion or they reported taking action to make their pandemic-related expansions permanent. On the other hand, 1/4 of the states reported new restrictions. The most common was putting new limits on audio-only coverage, often driven by quality-related concerns. Now, telehealth will remain an area, it's likely to remain an area of active policy development in the coming years, as more than 3/4 of the states told us that they had at least some questions or concerns related to quality, and most had implemented or were planning to implement a telehealth quality assessment. States also reported that state legislation, federal guidance, cost concerns, and a desire to protect member choice were factors that could also influence policy development in this area going forward. Next slide, please. Now, as Libby noted earlier, most states rely on managed care arrangements. However, managed care provider rates are often benchmarks to fee-for-service rates. And so, like we usually do, we included questions this year in the survey about fee-for-service provider rate changes. Consistent with the last 3 surveys, at least, the number of states reporting at least one fee-for-service rate increase greatly outnumbered fee-for-service rate restrictions in both fiscal 22 and fiscal 23, about twice as many states with reporting at least one increase. Also, as in most cases, those rate restrictions that we heard about, those tended to be rate freezes for inpatient hospitals or nursing homes, which for purposes of our survey, we include and count as a restriction. Now, as you can see on this slide, rate increases for nursing homes and home and community-based services were the most common across the states as states acted to address direct care workforce shortages. And in some cases, states reported double-digit increases for these provider types. We also saw an uptick in dental rate increases compared to surveys in the past few years. Finally, states reported that comprehensive rate reform initiatives impacting multiple provider types have been completed or were underway, and some noted growing calls from providers and others for higher rates in light of worsening inflation and higher labor costs. Next slide, please. Now, pharmacy remains a concern, as it has for many years, with more than half of responding states reporting at least one new expanded pharmacy cost containment initiative. These include, for example, initiatives aimed at pharmacy benefit managers and spread pricing, value-based agreements with manufacturers for certain high-cost drugs, and uniform preferred drug lists that states use to help maximize their supplemental rebates. Also, a few states reported carving out prescription drug coverage from managed care. California did that last January. Ohio launched its carve out earlier this month, and New York plans a full carve out next April. Also, a few states reported requiring all MCOs to contract with a single PBM that is designated by the state. Next slide, please. Now, every year we ask states about their top priorities for the year ahead, and it's not surprising that this year a priority shared by all states is the need to prepare for the unwinding of the federal public health emergency and return to normal operations. In particular, states reported that the resumption of eligibility redeterminations at the end of the PHE will be an enormous challenge, requiring a surge of administrative resources. Many states also reported that increasing COVID-19 vaccination and booster rates and improving preventive care utilization, which declined during the pandemic, were ongoing priorities. States also reported a renewed focus on other priorities that may have been deferred or delayed or exacerbated by the pandemic. For example, new and expanded initiatives to reduce health disparities, improve behavioral health access and behavioral health continuum of care, and advance quality through value-based purchasing. Now, finally, state Medicaid programs cited future fiscal and political uncertainties related to the expiration of the pandemic-related enhanced federal matching rate and outcomes of gubernatorial elections in 36 states next month. As always, it is an exciting and challenging time to serve as a Medicaid director, and I'm looking forward to hearing perspectives from Diane at the NAMD and the two directors that have joined us today. And at this time, I'll turn it over to Diane.
Thanks so much, Kathy. And I also want to echo thanks to our partners at Kaiser and at HMA for your continuing collaboration on this annual event. You've been capturing the evolution of the Medicaid program for 22 years running, and that's just amazing. I also want to thank the Medicaid directors, the 56 Medicaid directors that we represent. It's just an honor to support you and your teams. So from the national perspective, I'm going to focus on 3 themes that can situate us before we turn to the Medicaid directors from Indiana and Massachusetts to dive into state-specific information. And the 3 themes are state agency workforce, activity at the federal level, and then upcoming elections and the potential for leadership changes. So in terms of state agency workforce, during the pandemic, Medicaid played the role it was intended to play. It was the country's safety net. It did exactly what it was meant to do, and it was critical to saving thousands of lives that needed healthcare in the last couple of years. Now it's time to unwind from all those changes that states put in place. So no doubt the PHE unwinding will be the dominant issue for the foreseeable future. And states are as prepared as they can be. They've been working diligently from strategic planning, budgeting, systems work, eligibility, communications, et cetera. States are crouched and ready at the starting line. Here's the concern. The state agency workforce has been significantly compromised. The average vacancy rate this year is 17%. It was the same as last year. And 1 in 4 Medicaid agencies have a vacancy rate that's over 20%, and in some cases in the 30s and even the low 40s. So the challenge is having the state workforce that is ready and able to do the unwinding and also carry on the regular course of business. So that's the first contextual item. The second one is federal activity. And there's a considerable amount of it happening from our federal partners. CMS has a very robust regulatory agenda, and it will have significant changes for how states operate. And just highlighting a couple of pieces, CMS has reopened the continuous coverage regs from the Families First Coronavirus Response Act for comment. So there's a possibility that states will be rewinding while unwinding. So wrap your head around that. The second thing is there are expansive proposed eligibility, enrollment, and renewal regs. It may also happen during unwinding, and if so, that would create, again, major work for the states. Finally, Congress is a wild card in all of this and could make decisions before the end of the year that might undercut the planning and preparation that the states have been doing. So all of these create a potential for distraction for states and also potential confusion for Medicaid members. And then the third contextual piece is leadership changes. Kathy already mentioned it. Again, we have 36 upcoming gubernatorial elections, and these can lead changes in leadership at many levels. And Medicaid is shaped and administered by states. So the program can look different in every state based on the priorities of the elected state leadership. And we know that Medicaid programs ebb and flow with the prevailing elected leadership at both the state and federal levels. So it's critical to make sure that elected leaders have the information needed to understand the complexities of the program, what's possible, what's not, the trade-offs, and the nuances as the program continues to evolve. So again, state workforce, federal activity, and then changes with the upcoming elections. So Robin, I think those are my comments. I'm going to send it back to you now. Thank you.
Great. Thank you so much, Libby, Kathy, and Diane. That was a great presentation of overview of the findings from the report and national picture. So I think we are now going to turn to our panel discussion and hear from Medicaid directors. Welcome. So I was hoping to start our discussion if both of you can provide a sort of 100,000-foot overview of your program and also highlight maybe 2 to 3 of your top priorities for the program that you're thinking about as in this fiscal year. So maybe we can start with Allison.
Thanks, Robin. Hello, everyone. Thank you for having me. Happy to open it up and give you some perspective on the Indiana experience, and then look forward to handing it over to Amanda, because I'm always inspired by the work that Mass Health does. But from an Indiana perspective, we're pretty representative of the kind of the delivery system makeup that we would have heard Libby talk about from a national point of view. We have about 85% of our program run through capitated managed care. We contract with 5 health plans. We have 3 managed care programs here. We cover expansion adults in our program, and much like my other counterparts in other states, we've seen tremendous enrollment growth. Pre-pandemic, we typically had around 1.4 million Hoosiers in Medicaid. Right now, we're well over 2 million as the maintenance of effort continues. So that's a view of Indiana. I would love to feature or give you some insight into our top priority here in Indiana. And it is long-term services and supports reform. So I've already heard the word come up a few times today. And certainly we are really trying to be intentional about taking the momentum from the public health emergency and response to make structural changes to our program so it's better for the folks that we serve. And I think that's a theme nationally. You'll probably hear from Amanda, and if you were to talk to any of my other counterparts. And for us, LTSS reform has been a passion project for several years. It was actually a priority heading into the pandemic. And then certainly during and on the backside, just reinforce the urgency for us in Indiana. We have our aging folks and their families, caregivers, providers. We have quite a disjointed system currently. We have inconsistent experiences across the state. Not all of our processes and tools are as person-centered as we would like. And we have a tendency to be over-institutionalized and kind of on the bottom scale of rebalancing. And so I think our health outcomes kind of reflect that fragmentation. So the pandemic really highlighted the urgency of our work to try to flip the system, to change it. We found during the pandemic that oftentimes we really lack tools to get people home. So, workforce, streamline eligibility, communication tools, and even just community awareness. And so again, we had started the work in 2018 and 19 to bring our stakeholders together, talk about how do we do this better. And then on the backside of the pandemic, really, again, galvanized, because not only the pandemic impacted our work, but also, I think we have significant urgency to ensure equitable access across communities in Indiana. And so for those 2 reasons, again, for us, priority is LTSS. I'll just feature one sort of cross-cutting theme, and I'm sure this won't be the last time I mention LTSS in the next hour, but for us, we are moving to a managed long-term services and support system. So we are building a program. I think we might be the first state building MLTSS in a post-pandemic or nearing post-pandemic environment. So taking those lessons learned, focusing on a few things. So 1, person-centeredness. So we'll have comprehensive care and service coordination that actively involves members and caregivers and puts them in the decision-making seat. And so being very, very, very intentional with this aging population and moving to managed care. We're looking for a lot of administrative simplification for members and providers. So we're partnering with our health plans to make sure we have standardized prior authorization, claims processing, credentialing. Those things to foster a streamlined provider experience are top of mind for us in all of our programs. We are looking for increased health plan accountability and performance expectations. So both on our end, So as a state, really growing our internal acumen to be the best at managing managed care through staffing and organizational structure, policies, procedures. And then on the plan end, right? So they too, increasing performance, we're enhancing contract alignment, we're focusing on transparency. So really strengthening that partnership. And a last piece for our LTSS reform, and then I'll hand it over to Amanda because I can't wait to hear what she has to say, but we are also really including Medicare alignment in our MLTSS reform. So making sure we are not missing out on that really important aspect of the lived experience of a lot of our Medicaid members. So that is keeping us very busy and is very timely given all of the insight that that the panelists so far have presented. So I'll hand it to Robin or maybe Amanda. I'll go on mute. Thank you.
Great. Yes, let's hear from Massachusetts. Thanks.
Thank you, Robin. Thank you, Allison. First of all, again, want to thank the Kaiser Foundation for hosting this event. I'm really glad to be here today. And it was so exciting to hear about the work that Indiana is doing in the LTSS space. We are also doing a lot of work in LTSS and particularly around transitions and diversion from nursing facilities to community-based settings. But in the interest of highlighting a few different topics today, I'll focus on some different priorities. So the three top priorities that I want to highlight today are the public health emergency unwinding process, behavioral health, and health equity. I won't spend too much time on the unwinding process since folks have already spoken to it. It is the top priority for, I would venture to say, every single state. We don't have much choice about that. Coverage is, of course, the foundation and the baseline for everything that we do. So we are fully committed to a process that is as smooth and clear as possible for members that really ensures that folks who remain eligible, stay eligible, and one that really comes at it with an equity lens, which I'll speak more to. I guess before I get into that, I should just give a brief kind of overview of Mass Health. We are the Massachusetts Integrated Medicaid and Children's Health Insurance Program. We're actually similar size to Indiana. So pre-pandemic, we were at about 1.8 million members, and currently we're at 2.3 million members. We just hit 2.3 million. So that's nearly a 30% increase as a result of the maintenance of effort requirements during the public health emergency. We cover about 40% of children in Massachusetts and about 60% of individuals with disabilities. We are also an expansion state, so cover non-disabled adults. And we have a mix of fee-for-service and managed care. For our non-duals population, about 80% of our members are actually in an accountable care organization under our 1115 demonstration. So a model that really focuses on paying for value in terms of quality, total cost of care, and member experience. So that's a little bit of background about our program. Want to speak a little bit more to behavioral health and health equity. So you'll definitely hear a theme here, like Indiana with LTSS. We were very focused on behavioral health before the pandemic. In 2019, we did listening tours basically around the state, where I had the privilege to go around with several of my colleagues to different communities and to hear from individuals, from family members, providers, and stakeholders about their experiences with the behavioral health system or lack thereof. And the challenges that they had accessing the services that they need, and how much folks depended on the emergency department as a place to get treatment when they were in crisis and really didn't know where else to turn. So this situation has only become more urgent as a result of the pandemic, as we've seen demand for behavioral health treatment services surge, as we've seen the incredible toll that the pandemic has taken on folks' mental health, and particularly so for children and for folks of color. So we have continued that effort. Early in 2021, we put out what we called a roadmap for behavioral health reform, and we are now well into the road to implementation. We actually have some major components of that effort that are going live in January. We'll have statewide coverage with a network of community behavioral health centers. that will provide urgent and ongoing evidence-based treatment for both mental health and addiction. They will also be providing 24/7 community-based crisis intervention services. We'll also have a 24/7 helpline that will be available for anybody in the state to call, regardless of whether they have Medicaid or any other kind of coverage or no coverage at all. Folks will be able to call and get help in real time with finding services that meet their needs. And the helpline will be able to deploy those crisis teams as needed for anybody in the state. So those are some of the things that we have going on in behavioral health as a top priority. And in terms of health equity, this is something that we were working on prior to the pandemic, but I think all of us have seen just how deep and impactful structural inequities and structural racism have been on people's health outcomes during COVID. And so we have shifted to really be more explicit and more targeted in our strategies to address health equity. Our 1115 demonstration was approved just a little less than a month ago. That's a 5-year demonstration project, which really places health equity kind of at the center. We think about it as another pillar of value-based care. So you think about quality, you think about cost, and now we think about equity. And that's kind of the third leg of that stool for value-based care. So we'll be able to hold our accountable care organizations and our hospitals accountable for actually closing disparities over the course of 5 years in areas like maternal health, and other key indicators. And we also have a number of programs that really focus on health-related social needs like housing and nutrition and how those impact health outcomes. So I'll stop there so we can move forward with the discussion.
Great, thank you both so much. I was wondering, and you've already touched on this a little bit, but certainly the pandemic has been extremely challenging and challenging to run a program during the pandemic. And you've highlighted some of these priorities that have risen to the top priorities. But I'm wondering if there are any other lessons learned from running your program that maybe you can share. You know, in the survey, we highlight some things like cross agency collaboration or engaging with both providers or enrollees, collecting data. I don't know if some of those things were true in your programs. Maybe you can highlight some of those lessons that you've learned. We can start maybe with Massachusetts this time. We'll go back and forth.
Sure, happy to. Yes, it's been an interesting time for all of us. You know, I actually kind of want to mention some, I don't know, some more qualitative rather than quantitative lessons from the pandemic. So first, just want to say we are state government, and we are usually not considered the fastest movers or the greatest innovators in the world. But what we found during the pandemic is that actually we are. We are incredibly nimble, incredibly creative, incredibly good problem solvers collectively. And that in some cases, we were able to actually move even more quickly than other areas of the market and to really lead the way. We have deeply mission-driven staff who care so much about our members and about making sure that our members have access to the services they need and could stay safe during the pandemic. And they are so valuable. And so one of the workforce struggles, and Diane was mentioning the challenges with the state Medicaid workforce, that is true. But we also have had to kind of figure out different ways to really recognize and value our staff for the incredible work that they did do during the pandemic. Just as a couple of examples. So we were within a couple of days of COVID becoming a public health emergency, we had issued a broad telehealth coverage policy, really before anybody else in the state had done so. And that became the standard to which private payers in Massachusetts were held throughout the pandemic, was that they had to do at least what the Mass Health program was doing. We also were at the forefront of developing an in-home vaccination program, of supporting our long-term care facilities, and finding ways to keep our providers afloat at a time, like our day programs for long-term services and supports, at a time when otherwise they might have gone under, and those services might have been gone forever for our members. But the other thing that I want to say is that we also, I think, came to appreciate how important it is to listen and to pivot. We were all moving really quickly, and as proud as I am of many of the things that we did, we also, of course, made mistakes along the way. But we always stayed in close communication with our stakeholders. We also always continued to listen to our advocates and our members and providers, and we pivoted. And we owned up when we made mistakes, and we shifted course. And that I think has built a really important kind of depth of trust and relationship with stakeholders, even more so than we had before the pandemic, that will be a good foundation moving forward for those partnerships.
That was really helpful.
Yeah. Oh, okay. So very similar themes, to the point of responding in difficult times. And Kathy, I think you hinted at this too, like so much left off the whiteboard, or it would be nice to do this, or if only we had time or capacity to fill in the blank from, telehealth definitely stands out. That had been on our list. Some of the rate work, which we'll probably hit on in a little bit, but just thinking comprehensively and holistically about reimbursement methodologies, really focusing on home and community-based workforce for us in particular, partnership with our Department of Health and 211 on vaccine registration, and really kind of hitting the ground running and sharing in this cross agency in particular, kind of across lines of government. Really, Indiana demonstrated a commitment to really sharing the data, being member first. So we did not have some of the challenges between like Medicaid and health that you might have heard about nationally. So really just solutions oriented. So a lot of that, the waivers that we, both for hospitals and nursing homes, really trying to kind of outside the four walls, all of those are aspects that I think tell us that we can get creative and think a little bigger picture when we return sort of to normal. And I say that word because I don't know that any of us really want to go back, in particular on stakeholder engagement. I'll just share a couple of reflections. Amanda hinted at this, but we were accessible and nimble and inclusive in ways that we had not really dreamed of before. And so I think it would be a shame for us to go back. I've got a couple of examples just in the LTSS space, but this applies to kind of across the board. We really engaged in actually 2 years of community conversations and surveying. We rethought state processes to make them a bit more accessible and inclusive. So we have a group of, we let stakeholders, providers, families, caregivers come along with us to do initial planning and development of the request for information that would go out to market. We had stakeholders, they contributed 75% of that. And in a really unique process, we partnered with our Department of Administration to make scopes of work from our MLTSS writing available and posted publicly, so stakeholders could see their fingerprints in the process as we went. And so they could really kind of see that we were being inclusive of member and family needs. We've had almost 400 stakeholder meetings and tons of different formats, methods, modes, electronic in the community. So it's sort of the new way of doing business. And I know we don't want to go back, states don't want to go back. Just thinking about how to make government more accessible and putting member feedback at a premium. And so for us, I think that's really the biggest lesson learned, and where we will be really focusing on making some of those, a part of the fabric of what we do and not an exception. So.
And I just have one last question. As we look ahead, you're already in the midst of fiscal 2023. I'm wondering if you can talk about some of the biggest challenges that you see lying ahead. Again, I think some of these already surfaced a little bit, so the things that might keep you up at night, but also the biggest opportunities, things that you might be really excited about looking ahead on the horizon for the Medicaid program. And we will then jump into some Q&A from folks that have sent in. So we could start with Indiana this time and then.
All right. That sounds great. So common theme, but Diane mentioned it, Amanda mentioned it, everyone's mentioned it, workforce. So just flagging that, again, to the point of being creative, solution-oriented, Medicaid alone can't solve it. We are in Indiana focusing on rate matrix work. So at least trying to get our rate methodology practices on a transparent and predictable timeline so providers can have some stability and predictability there. It won't solve all the problems, but I think is a nice tool in the toolbox for sustainability. We also are really focused on direct service worker development. And so we've partnered with our local academic institution to review really top to bottom all the different ways that we regulate and license and work with our direct service workforce. We're finding it's quite patchwork quilt of expectations. And so we're going to be looking at really trying to align and streamline. We have a DSW advisory committee. We put out a call and we had almost 100 folks from across the state jump in and say, hey, we want to help be a part of strategically kind of building and growing this effort. So leaning really into that DSW committee and thinking about how do we really lift up and leverage and engage a really important workforce. And then also, flagging PHE, return to normal eligibility operations. It's important to remember there are a lot of Medicaid members who maybe don't know, they joined Medicaid during the PHE and they know nothing different in terms of eligibility processes and procedures. So really making sure we are communicating and connecting with members so they know they're gonna have to do something. There's things coming. And so we've been really trying to think through how do we do that, but also our eligibility team, I kind of view them, they're kind of like our central nervous system of the whole program. Everything kind of touches them. And so balancing the workload, and I know Diane mentioned some competing priorities with the rewind of the unwind, or you said it great, Diane, however you said it, but balancing those things and layering on whatever programmatic efforts and reforms that we're trying to undertake, just need to be really aware and intentional that the PHE is going to have an impact on capacity to do some of our priorities. But Amanda, what do you think?
I agree 100%. Workforce. It is the elephant in the room of every discussion. So I would really just echo what Allison said. The only things that I would add are in terms of potential looming challenges. It was really kind of the broader economic picture in the country. Inflationary pressures obviously put pressures on our members, but also on the state and on rates, which are really challenging to manage. And if the economic picture shifts and we don't have the same level of revenue coming into the state to be able to make additional investments, it creates a real challenge. So we're kind of watching those broader economic trends carefully. On the flip side, from an opportunity perspective, there is a lot of momentum that's very exciting. Both coming out of the pandemic, but also coming out of excitement around, for Massachusetts, our recent 1115 approval. And a ton of work that we are really excited about and that our stakeholders are really excited about to kind of continue down the path of restructuring around accountable care and really focusing on investments in behavioral health and primary care to kind of go upstream.
Great. Well, I think that was a great overview, and I think we're going to turn now to some of the questions that I think we're getting in our chat. So keep those coming, and if we don't get to all of them, we could potentially follow up afterwards. But I'm seeing and just picking up on some of these last comments that you made about workforce. We have two questions. One is related to how Massachusetts and Indiana might be thinking about efforts to expand community health workers. So on expanding capacity there, but also if you want to talk about workforce at the state level, if there's any plans thinking about eligibility workers and hiring, given issues with state capacity to move towards unwinding. So two very different but important workforce issues that you can maybe try to shed some light on. Either state.
Yeah, so I can comment on community health worker. We were one of the first states to get, I think, state plan approval to reimburse for community health workers. Now it's tied in a bit of a medical model, so we've had some experience where we've not seen the growth that we would have liked. So we are really, it is in one of our active evaluation areas where we're thinking about ways to improve, whether it's tiering reimbursement for community health workers or how we can leverage them. And again, it's all about getting into the community. So having that, those culturally competent bridges in the community. So I would say we're a state to maybe think about, take a look, but then we have some additional investment to do. Certainly our DSW work sort of complements some of that. I don't know, Amanda, and Robin, I forget the second half of the question, but Amanda, I'll see if you have anything.
Sure. So just quickly on the community health worker piece. So we've taken a slightly different approach. We have invested in community health workers really in the context of accountable care specifically. So rather than reimbursing fee for service for community health workers, what we've done is build in both funding and flexibility and requirements, increasingly requirements for providers to utilize community health workers as part of a team-based model of care. So as an example, one of the changes that we'll be launching early in 2023 is a new model of reimbursement for primary care. So we'll be doing a sub-capitation, a per member per month payment for primary care under the umbrella of our ACO program. And as part of that, there are a few tiers, and those tiers are both tiers of kind of expectations of for care delivery, for integration of behavioral health, and other pieces of primary care, but they're also tiered relative to investments. And as part of that model, we're encouraging primary care practices to implement team-based care that includes community health workers, and that also includes peer workers to support individuals and families. And so some of those costs are built in to the investments that we're making. In our prior waiver, we had some district funding from CMS, and part of the use of that district funding was to both directly train community health workers across the state and help support them through a certification process, and to provide funding to ACOs to invest in community health workers as part of their reform models.
Great. I think we had a few questions about effects on managed care and financing and trends related to delayed medical care that may have happened during the pandemic and what that means going forward in terms of acuity and managed care rates, and thinking about catching up on some of those delayed care that might have happened, if you have thoughts on those things.
Sure, I'm happy to start with this one and then pass it to Allison. So definitely really important concerns. In terms of delayed care, one of the things that we have been able to do is establish data sharing with our Department of Public Health. We started with COVID vaccine data sharing, of course, as part of the pandemic. And we were able to build on that partnership to start sharing just regular routine vaccination data, which we hadn't been able to do previously. And of course, given claims lag, it is hard to kind of keep up in real time with where kids are on routine vaccinations. And so having that partnership with our Department of Public Health has allowed us to track that more closely and share that with our providers so that they can then act on that information. And that's just one example of one of the ways in which we're trying to get better data to really understand what's going on with deferred care. It's also a reason why, among other reasons, why we have maintained a really broad telehealth policy and maintained parity in our payment rates for telehealth to make sure that there are minimal barriers to access and that folks can really get in to see their provider and catch up on deferred care in whatever mode makes most sense for those individuals and those providers. So we're definitely tracking it closely. It is a real thing for sure. And we'll be continuing to work with our providers and ACOs on trying to catch up. In the managed care rate space, we have what we call a market rate corridor. So a risk corridor, a market risk corridor, so that we look at the market overall. And if the entire market is in substantial gains, there's a risk corridor around that. Or if the entire market were to be in substantial losses, there's a risk corridor around that. In addition to individual plan level risk corridors. So we kind of look at overall what is happening across the market and tracking that to make sure that given all of the shifts in timing of the PHE and the impacts on the per member costs associated with that, we're not overpaying or underpaying as dynamics continue to shift.
Yes, Amanda, right on the mark. One benefit I think of having kind of that ACO, MCO, risk-based or incentivization of payment structure. So we can incorporate, we are focusing on having our plans increase vaccination rates, increase preventative care, increase preventative screens. And so really focusing on directing and focusing the opportunity of health plans to really get in the community and increase those levels. So that has been definitely a focus for us to help us be a tool in the toolbox. Like they are there to help us improve those numbers. And so really leaning on them.
Great. I'm not sure if we'll have time for one or two more questions. So I'll ask this one. We got a question about, I think we're so involved and we know a lot about and are anticipating the end of the public health emergency, but there's a question about what do we think, or what do you think that most people don't understand about this issue from regular folks to policymakers, that it would be important from your perspective that people understand about the unwinding process?
I'm
Great,
happy.
Diane, do you want to take that one?
Diane! Totally uninvited, but it's a great question. I would say two things. Just the fragility of state systems and the challenge around that states are facing with their information systems. I think that, and the second thing is the need for the steady state for states to be set up for success in the unwinding process. So keep the steady state, no quick moves, no deviations from the plan that is in place. So I would offer those two things.
Yeah, that's great feedback. And one message that we are that can be difficult as well is that when we do go through redetermination, there are folks that are going to be no longer eligible for coverage. And so balancing that, making sure there's a warm handoff and members are ready and have plans. And for like legislative and other policymakers, there will be some appropriate thoughtful disenrollment along the continuum, hoping we have that nice long runway and the opportunity. We want to do that do a thorough sort of eligibility process, but also recognizing that coverage will look different. Like we will have lower levels of coverage on the back end, as would be expected, is another message that trying to balance expectations.
The only other thing I would add, and very much agree with Diane and Allison's comments, is that this is not going to happen overnight. States have about a year, they have a year to initiate eligibility renewals, and we've got a whole lot of members to go through the process with. So part of the balance that we're trying to strike is getting out the message far and wide and as clearly and simply as we possibly can about the process and the need for members to respond when they do receive renewals, but also understand that it's not as if, all 2.3 million of our members are going to receive requests to renew their eligibility on day one of the end of the PHE, and they're all going to be acting at the same time. This is going to be, an extended process, and it's going to require ongoing kind of attention and partnership with our providers and our advocacy organizations and our community organizations around the state to continue to reach out to members and for folks to respond to that envelope when it does come, even if that is 7 months into the process.
Great. Well, we have a lot of other questions that we're not going to get to, but I will just say there's some on behavioral health, on equity and how to measure that and measure progress and what we're looking for in terms of data on behavioral health. So I will take that opportunity to just say that there's a lot of detail in the report that folks can read up on. And we also have some other content that's forthcoming. We also fielded this year a addendum survey related to behavioral health. So we will have a lot more coming out on behavioral health, but we will try to do some follow-up on the questions that we didn't get to. But I want to be mindful of everyone's time and thank everyone again for participating, for tuning in, and for our panelists for participating in this webinar. Like I said, stay tuned for other information, and thank you for joining us, and have a great afternoon.